KMCH Hospital, Coimbatore, working closely with multidisciplinary teams on treatment protocols, drug safety, and aseptic chemotherapy compounding. Mr. Venkateshan Sir is also an active member of 2025-26 ISO PP Awards and Travel Grant Task Force for the International Society of Oncology Pharmacy Practitioners, contributing to award review processes and the development of new procedures. His research and project portfolio covers diverse healthcare topics from assessing antibiotic prescriptions in public health settings to evaluating the safety and effectiveness of advanced antibiotic combinations in chronic kidney disease patients. He has also concluded studies on chronic heel pain in prolonged standing workers and on communal factors influencing COVID 19 spread. Committed to continuous learning, he holds certifications in research methodology, clinical trial disease assessment, ACLS, and advanced cardiovascular life support. His academic contributions include conference presentations at prestigious events such as APP Annual International Virtual Convention, the ICCPPR Conference, and the International Conference on Invocations in Molecular Medicine and Translational Research. A skilled communicator and collaborative professional, Illumila Venkateshan Sir combines clinical expertise with research driven practice to improve patient care, optimize treatment protocols, and advance oncology pharmacy on a global scale. Now, the virtual stage is yours, sir.
Yes, thank you so much for the warm introduction. Am I audible?
Yes, sir,
Hello?
you're audible.
Yes, let me share my screen. Is my slide visible?
Yes, it is visible now.
Okay. So good evening, everyone, and thank you for the host for giving a warm introduction about me. So myself, Dr. Ilmali Venkateshan, I'm working as a hemato-oncology clinical pharmacist in KMCH Hospital, Coimbatore. So we are going to discuss about the role of clinical pharmacist in hemato-oncology department. Going directly into the topic, first and the foremost thing that as a CP we do in our department is the dose calculation. Even though the protocol that we receive in the daycare unit and what is everything is pre-checked and filled by the medical oncologist or hematologist, we have to double check the dose. In our family or in our internship, we would have learned about how to calculate the uh, drugs dosage based on the weight, but most of us would have not never heard about the body surface area, or we don't usually routinely use the body surface area in calculating the drug. So basically, we calculate it based on the height, weight, and so this is the basic formula. We use it. For example, we take a drug, paclitaxel. So we receive a protocol as 80 mg per meter square or a 60 mg per meter square. A normal person's BSA would be around 1.6 to 1.8. Based on that, we will calculate. Most of the time, we have corrected the dose by uh, saying it to the consultant that this may not be the correct option or this may not be the correct dose. So another thing is weight based. Since most of the chemotherapy patient will have certain side effect like taste bud changes, their food habits changes, and they gradually reduces their weight in the upcoming cycle. And we play a crucial role in calculating the dose in the subsequent cycles. And also, a particular drug we normally come across in our department is carboplatin. This drug, we calculate the dose based on the AUC, just using the creatinine clearance formula and multiplying with the AUC. Mostly, the dosage will be expressed in 2 to 6. And also, just like the other drugs, we used RFT and LFT. Uh, a drug, Vinca alkali drug, it is vincristine. The common side effect is neurotoxicity and LFT derangement. And we are not supposed to give this vincristine drug when the total bilirubin goes greater than 3. So, like this, there are many drugs in our oncology department where we particularly analyze and cut down the drugs based on the patient lab and lab parameters and other stuffs. So another important thing is checking their labs. It is well known that most of the drugs we use in oncology will cause myelosuppression, which will subsequently reduces the total count, that is WBC of the patient. So it is mandatory for the CP to calculate the ANC, which is absolute neutrophil count. We calculated the formula I have given, that is the total count into the neutrophil divided by 100. So we have grading for the neutropenia. If the patient ANC goes less than 1500, we immediately inform the consultant, and we either change the date of the protocol, or we will cut down the drugs dose. So, or in some cases, we will proceed with the chemo, the same dosage the doctor prescribed, by giving GCSF, that is growth factor. I'll tell about it later. So another important pre-check parameter is seeing the vitals of the patient. It may seem very normal, but in some cases, I have faced that when the patient BP is elevated initially, we proceeded the chemo, not like without checking, where we do check, but in between the patient BP raised, and they had signs and symptoms like giddiness and faint. The patient have faint. So checking the vitals is also important pre-check parameter in daily routine of the oncology CP. Another thing is pre-medication. So we can classify all the chemotherapy drugs into three categories: low emetic, moderate emetic, and high emetic. Sometimes a physician may miss or may conclude high emetic drug as a low emetic and prescribe minimum anti-emetic drugs. To say, like, for a high emetic chemotherapy drug, we have to give 4 classes or at least 3 classes of anti-emetic, identifying the particular a type of anti-emetogenic. We can suggest the physician whether we have to go with the single antiemetic or triple antiemetic therapy prophylaxis. Yeah, and apart from this antiemetic, few drugs need supplements like magnesium and calcium in case of oxaliplatin. Oxaliplatin is well known to reduce the magnesium and calcium. And checking the labs, of course. Another thing is monitoring. After finishing up with the dosage and pre-check parameters, monitoring the drug infusion is also an important part. Uh, Certain drugs will have the doctor would have given a particular timing for the drug to end. For example, there is a protocol called RDA-EPOCH. In that particular regimen, the drug has to go for 96 hours, 4 days continuously. So in that case, not every time physician or other healthcare professional can see whether the drug is going in appropriate infusion rate or appropriate timing. As a CP, we will keep a set of things to notice whether these drugs are going in that particular time. And another example is rituximab. Rituximab is a most mischievous drug. We have if we say like in a month, if we have a 10 to 12 reaction, almost half of the reaction will be from this rituximab drug. And maintaining this rituximab infusion within 400 mg per hour, we can avoid this kind of reaction, anaphylactic reaction. And another drug, gemcitabine, uh, yeah, every particular drug will have a particular characteristics. So that's what I'm explaining. The gemcitabine is a drug which has to be given within 30 minutes. If we 30 to 45 minutes. If we exceed that particular time, this drug toxicity will be more. And yeah, if we pay and once if we get any reaction, like whether the patient SpO2 drops, or the patient is having breathing difficulties, or if the patient takes vomiting, we will be there will be a set of protocol that have been discussed with the doctor previously. So we will immediately ask the staff nurse to stop the medication, and we will give drugs from the anaphylactic kit just by informing the doctors. And after the patient symptoms settles down, we will re-challenge the drugs in the off of the drug rate that previously it has been going. And another important part in oncology daycare unit is patient counseling. Most of the drugs will be explained by the nursing staff, but there are certain drugs which has to be explained by us. Uh, One of such is Nucain and Pegdafil. Nucain is a growth factor that have been given to increase the WBC. We are the main aim of us to giving the chemotherapy is to reduce the bad cells. But parallelly, the chemotherapy drugs we are giving have the tendency to reduce the good cells too. To compensate it, we are to compensate the side effect, we are giving this growth factor, which will increase us the WBC. But we have to the one such characteristics of this particular growth factor is we have to maintain the cold chain, or else the drug's efficacy may go down. So uh, to say an example, every time I will ask the patient upon discharge where how much travel time you will take it for you to go home, and will explain them regarding the necessity of maintaining the cold chain. And another important part that we play in daily routine is telling the patient and patient attendant about the importance of oral chemotherapy drugs. Most of the and almost every oral chemo drugs should not be crushed or should not be chewed. It has to be swallowed wholly, and it should be handled only by the patient. Even it may be the exposure for the patient attender or the caretaker may be less, but it is a standard routine that the oral chemo drugs should only be handled by the patient, and maintaining the time gap. It's not like oral chemotherapy drugs won't won't have the characteristics of the normal drug. If it has to be taken in that particular time, it has to be taken in that particular time. And the we will explain the importance of maintaining the time gap. And another important counseling is explaining the patient and the patient attendant about the chemotherapy drugs excretion in the body fluids. Many patients have asked whether we can play with the children or with the family members. We can whether we can be normal. So we have to explain to flush their toilets double times, and there are certain stuff we will counsel in the daycare unit. And in the ward, the following things I will follow in the ward rounds. So we will have a routine rounds with the doctor, and we will be adding and deleting drugs based on the patient clinical status. For example, we will add and delete NSAID pain tablets and other prophylaxis regimen. There are certain prophylaxis regimen that need to go for in a particular time. Once we stop the drug, this prophylaxis need to be stopped. For example, PJP prophylaxis, that is ceftriaxone and bactrim DS. All the chemotherapy patient who are taking corticosteroid or they're having concurrent radiation plus temozolomide, and whether they have infusing with the proteasome inhibitors like bortezomib, they need a ceftriaxone prophylaxis. And and another thing we do in the rounds is informing the doctor about the availability of the drug. Based on it, the doctor decision on treating patient with that particular decision may change. So drug adherence. Um, Not every patient will have the thing to pick up about the importance of the drug. So we will just involve ourselves in the pill count and the in the number that have been done by the staff to check the drug adherence of the patient, and informing the doctor about the difficulties of the patient to take the particular drug, and suggesting the doctor regarding the availability of the different formulation of a particular drug will help the patient to increase their drug adherence with that particular drug. And also, we play a crucial role in patient affordability. In a developing country like India, based on the patient affordability and their financial status, most of the drug regimen a physician chooses may change. To be more precise, I will give a common example. We do have when a patient goes to neutropenia and comes to the hospital with neutropenic fever, and we will initially treat them with carbapinums and other BLBLIs. If the fever doesn't settle, we will escalate the antibiotic to ceftazidime, avibactam, and nab-sirolimus. In our formulary, we do have different brands with the different price. Uh, the efficacy may changes, but if the patient affordability is more, we will go for a more of a innovative brand. If the patient don't have much financial status or they don't have any insurance, we will go for a much more affordable brand. This goes same for chemotherapy drugs. And another important thing that we do in our routine work is reviewing the hematopoietic stem cell transplant protocol for their appropriate dosage. And not like common routine chemotherapy drugs. We use clinical studies and clinical trials to calculate the appropriate dose for this protocol. We will give extra care while reviewing this kind of transplant protocol, because not, from the usual chemotherapy protocol, this protocol will have a higher dose of chemotherapy dosage, and another is dilution. Uh, it may seem very simple, but a small change in dilution or the infusion rate can have an impact on that particular drug efficacy and the stability. So we will, for each and every drug, we will read the leaflet or the available drug information in lexicon and other sources for the drugs appropriate dilution, storage, and other prophylaxis needed for that particular drug, and will inform the physician. We will actually have a discussion before giving the protocol to the BMT unit. So it will be like a roundtable conference. And to tell about the prophylaxis, for a drug called Fludarabine, it has a main side effect of neurotoxicity. So that we will provide a neurotoxic prophylaxis uh, beforehand, and explaining and coordinating with the staff regarding the safe handling of chemo drugs. Not every not The senior staff won't be available in the BMT staff every time. So we will have a discussion with the BMT staff about the particular drugs characteristics, and what and all they need to do beforehand. So to say, like, busulfan is a drug which is excreted in the body of the patient throughout the drug. To say, like, from the day of infusion till 48 hours. So at that time, we should ask the staff to be more careful while handling the patient, and to wear personal protective equipment every time they handle the patient. And also, we should educate the patient attender to be more precaution on the day of busulfan and the subsequent 2 days. Yeah, thank you. And I didn't have much time to prepare a fancy slide, so I think I will end here. I think the host can take over from here. If anyone have any doubt, they can ask me.
Sir, can I?
Actually, there is a question. How should we overcome the emotional devastation we feel after a counseling session to a financial constrained patient? I think Shalini Prabhakar, she is also an oncology pharmacist. Okay. Uh, so after having a devastation feeling after a counseling session, not we can do much, but in our hospital we do have a funding department. We can ask them to help this kind of patient, but not much we can do with them. Only the emotional support we can give, and we can put more effort to say them. About the more affordable drug regimen or ask the physician to do the needful. Yes.
Sir, I think you have explained better that there are no more questions.
Thank you so much.
Thank you, sir, for your insightful session on the role of clinical pharmacists in hematological units. Your expertise and real world examples have deepened our understanding for specialized patient care. Thank you for joining with us in SYCCON Day 13, sir.
Yes, thank you so much. Actually, there is another question. Why body surface area is more important in oncology drug dosing? Okay. Actually, when we give a drug like paracetamol, even when it goes to some particular organs, like say, yeah, the normal side effect of paracetamol is hepatotoxicity. Also, the drug may go in renal and everywhere in the body it will go, but it will much affect particularly the liver. But when in talking about cancer drug, it goes everywhere, to the skin, all the mucosal membrane, to the brain, everywhere. Of course, not holistically, some drug. So that when we calculate the body surface area, we will have a control over the dosage to a particular organ. So based on that, only we are calculating the body surface area, particularly for the oncology drugs. But when we go holistically, the organ damage or the toxicity may be higher. I think there is another question. So, is there any particular work and action you take that focus on fluid and electrolytes? Of course, for fluids, just like uh, other department, we will see the input and output and patient uh, hemodynamic status, whether the patient have a puffy face or a pedal edema, like that. Nothing more of that we will do, particularly for a more nephrotoxic drug like cisplatin and other nephrotoxic drug will give more hydration with some magnesium and potassium supplement. And for in talking about electrolytes, we will have a regular check before, yeah, just like the pre-check slide I have been talked previously. before every cycle, we will have our electrolytes value beforehand. So we will check and proceed with the chemo. Chemotherapy makes the body weaker, even if the common cold can be serious. In that case, how can we do patient counseling regarding this common illness? Okay. In that case, prophylaxis is the only patient counseling we will do. Prophylaxis in the sense, if the we will counsel that your immune system may go down. So you have to be more careful uh, than the normal people. For example, if you telling them to avoid the crowded places, we cannot say now who have the flu and who have not. So we will ask them to avoid crowded places. In case if they can't avoid that, we will ask them at least to wear a mask and other personal protective equipment. And yeah, we don't give particularly any drug as a prophylaxis for the common flu, but we will ask them to take this kind of measure to avoid getting common flu and other infection. Yes, thank you so much. We do have a vast variety of therapies. I don't know what to tell about, but particularly in case of dilution, uh, we do have a drug called oxaliplatin and nanoparticle form of paclitaxel, which have to be diluted only in dextrose, not in normal saline. Uh, I don't know whether these kind of errors have occurred before, but we use the system of called the label system, where we write a label for a for each and every drug. Like this drug has to be only diluted in this particular diluent in this particular volume, and this information will go for the preparation unit. And we do have another section in the label column. Where the information will be more useful for the nursing staffs, like this particular drug has to be infused in this particular time and it has to be stored in this particular time. So for each and every drug, we will be writing label. Without a label in KMCH hospital, not a single chemotherapy drug will be prepared. So we do have this label system. So I think that would have answered that. There is another question. Do we, as PharmD graduates, have any role in vaccine administration or any other route of chemotherapy? Yes, actually, we do have a role in vaccine, but uh, particularly in our hospital, there is a drug called Fesbro. It is a combination of pertuzumab and trastuzumab. So usually the volume of a subcutaneous injection should be less than 2 ml or 3 ml, but this particular drug volume is 10 to 12 ml. So coming in a situation like this, uh, we as a clinical pharmacist can get involved ourselves in administering this kind of drug. So in our hospital, we are practicing this to administer high value Fesgo medicine subcutaneously for 10 minutes. Yes, we do have a role as an oncology CPs in administering drugs. I think that's the final question. Thank you so much.
Thank you, sir. Thank you all for joining today's session. Before ending, I would like to announce the agenda for tomorrow. The speakers for tomorrow are Dr. Alga P. Thomas, Dr. Rishma, and Dr. G.L. Preeti. And as scheduled, they'll be speaking on AMS in special population, deciding the future career growth as a product management executive, and why a clinical pharmacist is mandatory to get NABH. Before leaving, kindly fill the feedback form which is available in the chat box. And I hope you all will join tomorrow with the same enthusiasm. Thank you and see you all tomorrow.